Kristy. This is my BE trigger. So I'm going to start with all my supplies. So I have my barium and the barium bag hung. I have clamps and I have lots of towels, lots of gloves, the lead glove, the compression pad just in case we need it, lots of lube, and then I have the tip here, and on the tip we have the inflator. Make sure that it works, and then we have the air and all the barium hung, and we're ready to go. Okay, and we're going to set it up for the Scout KUV, and we're going to do about 75-80 at 30 for the technique, and then we're going to come and scout the patient. Elizabeth? Hi, Elizabeth and Kristy. So we're going to be doing your barium enema today. Just want to go ahead and give me your full name and your date of birth.
Elizabeth Reynoso, July 3rd, 1990.
Okay, and then is there any chance that you could be pregnant?
Not at all.
Okay, alright.
706.
Did you prep for this exam?
Yes.
Were you told about the prep and you had last night?
I ate at all and I'm starving.
Okay, and you...
I have no crap in my colon.
Alright. Well, we're going to take a picture first to make sure that your colon is clean.
Okay. It's clean.
I'm sure it is.
I'll tell you that.
And then the radiologist will come in after we start the procedure. So we'll go ahead and get you up here on the table. I'm going to go ahead and lay down on your back. And I have my 14x17 cassette in here. And we're going to center at the level of the crests. Make sure we're detented. Feel for your hips here. So we're going to shoot this at about, like I said, 80 at 30. So go ahead and take a breath in and let it out. And hold it out. Beep. So you can breathe. Alright, now I'm going to go show the radiologist, and then we're going to start the procedure. Radiologist has okayed the pictures, and so we're going to get the patient into the Sims position. Okay, Elizabeth, so I'm going to have you get into this position with your left leg forward. We're going to be inserting the tip, and I'm going to put lots of lube, generous with the lube.
Oh, thanks.
Yes, you hopefully won't feel a thing. So we're going to be inserting the tip, and we're going to be going 1.5 inches anterior towards the belly button, and then we're going to be going superior, following the curvature of the sacrum. So the tip's going to be going in now. Alright, you might feel some pressure. Go ahead and breathe through it. Alright, so tip is in. How are you doing? Are you okay?
Okay.
Okay. Alright. You okay back there? So we're going to be covering up the patient, keeping her covered. Alright, and then the radiologist is going to be coming in and inflating the tip, and then we will be raising this up. Alright, and now we'll get the radiologist. Radiologist has come in. We have the bag 24 inches above the anus, and he's going to be doing his spot films. So he's going to be doing his spot films, and I'm going to be turning it on and off. Elizabeth, you might feel some pressure. The radiologist is going to be doing his images. On, off, on, off. Okay. Okay. This has done all the spot films, and now we're going to do the overheads. Okay, Elizabeth, so we're going to be doing a couple overhead pictures now, so go ahead and get onto your side fully, your left side. And all these pictures are going to be done with the tip in still. Okay. So we're going to be doing the right lateral decubitus. Dang it, it's the left! That's okay, it's the left lateral decubitus.
Look, Mom.
Wow, big lateral. And getting it into the decube. Alright. by 17, and we're doing our left lateral DQ. We're going to be doing it about 90 to 110 at 30 to 40 kV. And we're centering at the crest. Alright, Elizabeth, go ahead and take in a breath and let it out, and hold it out. And there's our first exposure. So now we're going to go to the right lateral. Alright, so go ahead and turn onto your stomach, go forward. Careful there. Oh, okay. And now we're going to be doing, now we have the right lateral, decubitus. And we're going to be centering at the crest as well, and it's still a 14 by 17, and same technique. And this one is showing the waist of it, and also the horizontal beam centered at the crest. And then we're going to take this. Okay, so go ahead and take another breath in, let it out, hold it out. Alright, and then from that we're going to go to our obliques. The lateral rectum. So we have our film in. We're going to be doing it at about 90 to 100 at about 40 to 50, centering at the as is. Okay, then we're going to take that there. Doing our obliques. Alright, Elizabeth, if you can just roll forward for me. So we're going to be doing a 35 to 45 degree. The RAO, and we're going to be centering at the crest, still again at the crest. Alright, and go ahead and take that one onto your stomach here. The tip's still in, so just be careful, keep you covered. And now we're going to be doing the LAO. And it's still a 35 to 45 degree angle. And we're centering at the crest, 2 inches lateral. And we're going to take that picture. Okay. Doing a PA. Alright, so Elizabeth, if you can just roll onto your stomach. Keep you covered here. Alright, so we're going to center at the level of the crests. And we're doing the same technique. We're going to be doing about 90 to 100 at 30 to 40. Alright, so we're going to take that, and now we're going to do the PA axial, and we're going to be doing a 30 to 40 degrees caudal angle, and now I'm going to line up the two. Still entering at the level of the as-is. Too hard. So we'll take that there. And after this, we're going to do a post-evac. Alright, so Elizabeth, I'm going to have you get up and then go use the restrooms. And after I untip you, so I'm just going to pull out the tip. So just breathe through it. Okay, and tip is out. Lots and lots of towels. Lots of towels here, so we're going to do a post-evac picture after she uses the restroom. Alright, can you hold up? No. Got it? You okay? Oh shit. Oh god. Oh shit. Oh shit. Is this normal? Oh shit. Now I'm going to get it ready for when she comes back from the restroom. Is it okay if I didn't make it to the toilet? Yes, that's okay. How did it go?
It went okay.
Yeah.
Never shit so much in my life.
Okay.
Oh.
Alright, so we're going to go ahead and do one last picture.
I really need
by 17. We're centering again at the crests. And we're going to do a little bit less technique now because there should not be any more barium. So we're going to do about 75 to 80 at 30. Leveling the crest. And go ahead and take a breath in. Let it out. Hold it out. And that's it. We're done with that. Explaining to Elizabeth the post-procedure care. So you will be a little gassy. You're going to need to drink lots of water because barium it causes lots of constipation, and you will have some discolored stool, so just be mindful of that. There will be some discoloration in that, and then this is all for you, and then you're free to change it. Go. Okay. All right. Thank you. Yeah.
So the criteria for the PA projection is that there should be proper collimation, the entire colon, including the flexures and the rectum, and the vertebral column centered so that the ascending and descending portions of the colon are included. And we have our PA axial projection, and you want to have the proper collimation. You want to have the rectosigmoid area centered to the radiograph, and the rectosigmoid area with less superimposition than the PA projection because of the angulation of the central ray. The transverse colon and both flexures are always included. And then we move on to the PA oblique in the RAO position. And you want to have the proper collimation. You want to have the entire colon, the right flexure less superimposed or open compared to the PA projection, and the ascending colon, cecum, and sigmoid colon all included. Then we're moving on to the PA oblique projection in the LAO position, and you want to have the proper collimation, the entire colon, the left colic flexure less superimposed or open compared to the PA projection, and the descending colon. And then on to the lateral rectum, and you want to have obviously the proper collimation on that, the rectosigmoid area in the center of the radiograph, no patient rotation, the superimposed hips and femora, and the superior portion of the colon not included when the rectosigmoid region is the area of interest. And then we move to our decubes, and so we have the right lateral decubitus position, and the patient is AAP, and you want to have the proper collimation and the area from the left colic flexure to the rectum, no rotation of the patient, and that's shown by the evidence of the ribs and pelvis not being rotated. And for single contrast examinations, adequate penetration of the barium. For double contrast examinations, the air inflated portion of the colon is the primary importance and should not be over-penetrated. And then we go to the left lateral decubitus, and you want to have your proper collimation, the area of the left colic flexure to the rectum, no rotation of the patient, and the inflated portion of the colon that is the primary of importance. This should be shown the whole way.